A patient hits the door with an acute focal neurologic deficit. We're diving straight into the clinical decision-making pathway for stroke and TIA management for Step 2. Here is our roadmap for this explainer. First, acute focal deficit triage, then stroke subtypes and timing, vascular territory localization, reperfusion and BP targets, TIA and secondary prevention, and finally, complications and pediatric stroke. All right, part 1, acute focal deficit triage.
So your patient is here. First things first, check those ABCs. Then you need to nail down the exact last known well time. This is huge for treatment windows later. Grab a fingerstick glucose right away to rule out hypoglycemia, because that can totally mimic a stroke. Get a baseline severity using an NIHSS-style exam. And hey, don't forget to rapidly screen for recent trauma or an initial seizure and grab that blood pressure. Keep an eye out for headache, vomiting, or fever too.
Now for the primary branch point, an immediate non-contrast head CT. You have got to separate hemorrhage from ischemia. And listen, do not delay this scan waiting for lab results. Just get them to the scanner, unless there's a specific safety issue, like known heavy anticoagulant use. Moving to part 2, stroke subtypes and timing. Differentiating the etiology relies heavily on the time course. Embolic strokes, they're abrupt, maximal right on onset. Thrombotic strokes, on the other hand, usually have this stuttering progression over time. And intracerebral hemorrhages tend to progress steadily over minutes to hours, often throwing in early focal deficits along with headache, vomiting, or a drop in alertness. Let's look at some risk factor clues. Thrombotic ischemia frequently aligns with your classic vascular risk factors. Think hypertension or a history of prior TIAs. Embolic ischemia, though, often stems from a cardiac source, so you're looking for atrial fib, endocarditis, a patent form and oval, or carotid disease. If you see hyperintense blood collections in the subarachnoid space on that non-contrast head CT, you're dealing with a subarachnoid hemorrhage. Clinically, these patients present with that classic thunderclap headache and meningeal irritation, like neck stiffness, rather than early focal deficits.
Okay, part 3, vascular territory localization.
Localizing the lesion tells us what clinical deficits to expect. A middle cerebral artery or MCA occlusion is going to affect the contralateral face and arm way more than the leg. You'll see conjugate eye deviation toward the lesion, hemianopia, and often aphasia if it's the dominant hemisphere, or hemineglect if it's non-dominant. Now compare that to an anterior cerebral artery or ACA occlusion. That one emphasizes contralateral leg weakness over the arm, and you'll see things like abulia, dyspraxia, emotional changes, and urinary incontinence. What about the posterior circulation? Vertebrobasilar strokes affect the brainstem, which leads to those classic crossed cranial nerve and long tract findings. These patients frequently present with vertigo, ataxia, dysarthria, diplopia, or dysphagia. It's a completely different presentation. Then we have lacunar strokes. The key here is the absence of cortical signs. These are small penetrating artery occlusions, and they present as pure motor hemiparesis, pure sensory stroke, sensory motor, ataxic hemiparesis, or that specific dysarthria clumsy and syndrome. Keep in mind, you will not see aphasia, seizures, or altered mental status with these. Part 4, reperfusion and BP targets. This is where that last known well time comes into play. For an ischemic stroke within 4.5 hours, IV alteplase or tenecteplase is indicated, as long as you've excluded hemorrhage, of course. Now, from 4.5 to 24 hours, or if you suspect a large vessel occlusion, you need to grab a CTA of the head and neck. Eligible patients with a large vessel occlusion can then go straight to mechanical thrombectomy. But hold on, you've got to run through the exclusion criteria for thrombolysis. You're looking for recent intracranial bleeding or spinal surgery, active bleeding at a non-compressible site, platelets under 100,000, or glucose under 50. Major anticoagulation use, a large established infarct, or blood pressure stuck over 185/110 despite treatment are also exclusions. Minor, rapidly improving deficits? That's considered a relative exclusion. Speaking of blood pressure, managing those targets is critical. Prior to thrombolysis, you have to lower the BP below 185/110, and after, keep it below 180/105 for a full 24 hours. But here's the flip side. If thrombolytics aren't indicated, you allow permissive hypertension. You want to maintain perfusion to that ischemic penumbra, so you only lower it if it hits extreme limits, like 220/120.
For post-stroke safety, keep the patient NPO. Don't let them have anything by mouth until you've done a bedside dysphagia screen. Throw on some intermittent pneumatic compression for DVT prevention. And really important, after thrombolysis, you have to wait a full 24 hours and repeat head imaging before starting any antiplatelets or anticoagulation.
Moving right along to part 5, TIA and secondary prevention. If it's a TIA, these transient symptoms need an urgent diagnostic pathway to prevent a completed stroke. Get an MRI of the brain, followed by vascular imaging of the head and neck, like a CTA or MRA in a carotid duplex. You also need a cardiac evaluation with an ECG, prolonged rhythm monitoring, and an echo when indicated to hunt down any potential embolic sources.
For secondary prevention, you'll start antiplatelet therapy, unless, of course, anticoagulation is indicated for something like AFib. Add a high-potency statin, tackle those underlying risk factors, and consider carotid intervention if they meet stenosis criteria. Oh, and if the stroke is cryptogenic, prolonged cardiac rhythm monitoring is the way to go.
Finally, part 6, complications and pediatric stroke.
Let's talk about severe post-stroke deterioration. Malignant hemispheric infarction happens when a massive ischemic stroke, usually MCA or ICA, causes profound cerebral edema. This edema spikes the intracranial pressure and can lead to herniation within days. It's serious. It often requires an emergent non-contrast CT followed by a decompressive hemicraniectomy to relieve the pressure. Now, both malignant hemispheric infarction and hemorrhagic transformation present the same way, a deteriorating mental status a day or two after a large ischemic stroke. So how do you tell them apart? You get an emergent non-contrast head CT to distinguish the profound edema of a malignant infarction from the actual bleeding of a hemorrhagic conversion.
Let's wrap with a key pediatric edge case. If a child presents with acute focal deficits, do not just assume it's a Todd's paralysis mimic, especially if there's no clear confirmed preceding seizure. Children with a suspected acute ischemic stroke need an urgent MRI and MRA to fully evaluate that vasculature.